Now, I would like to invite Dr. Aditya Sethi, who will give us a talk on amblyopia, old disease, new regimens.
Hi, can you see my screen? Yes?
Yes, sir.
Okay, perfect. So I'm going to talk about amblyopia, what's latest in management of this forgotten eye. So I'm Dr. Aditya Sethi. I'm a consultant at Arunodaya Deseret Hospital. I'm a fellow from Sankara, Nethralaya, Chennai of Paediatric Ophthalmology. So no really financial disclosure here. And I have consents from patients. So like my guru, Dr. Meenakshi, I would always like to start with a little case discussion. So we have a 6-year-old boy from Chennai, discovered to have decreased vision on school screening. Left eye was 636, best corrected, and right eye was 66. The refraction was about +2 in the right eye, and left eye was a +6, and rest of the exam was normal, and there was no squint. So of course, this was an anisometropic amblyopia. There was refractive adaptation, and there's occlusion, which was given to the patient. So what's new here? Nothing. Really, but the challenge was ATS has made our life simple. It's told us how we treat amblyopia now with the occlusion, how many hours, is it as good as atropine or not? Yes, all the questions correct. But does it still hold? Now the dad was a doctor, so we had a nice discussion. So the dad said, "Doctor, when you are prescribing occlusion, aren't you doing precisely opposite of what you want to achieve?" So I said, "What do you mean?" So the doctor said, occluding one eye will prevent any binocularity from developing, right? And I was like, So good food for thought, isn't it? So another case, 21-year-old, recently diagnosed to have amblyopia, wants to know if there's any alternative to occlusion. Had enough of this occlusion. Are there any alternatives? Any computer-based therapies or medication? Case 3, a 6-year-old girl, allergic to patch, has had photophobia with atropine also. So patching therapy, what does ATS tell us? It talks about patching therapy varies depending on severity of amblyopia. It says atropine is as good as patching. It says you need to give refractive adaptation before you start patching. It talks about amblyopia in the teens. It tells us about the success rates if the previously treated amblyopic comes to you. And it also talks about recurrence if you stop immediately and we need to taper. We all know that. What are the various behavioral treatments available now? So we have now what we call is the perceptual learning. Is my video and voice coming accurately?
Yes, sir.
Okay, perfect. So what is perceptual learning? Any relative, permanent, and consistent change in the perception of sensory task following repeated practice. It's non-invasive, it's software-based, it's patient-specific, it's interactive, it's available as a mobile app, and patient sits in front of the screen wearing the best optical correction with dominant eye occluded. So this is the latest. We also have, these are different forms of perceptual learning. You can have stimuli and noise, you can have motion, you can have complex figures, you can have colors, textures, stereos, and fine forms. How does it work? It reduces by reduction of internal noise in the visual system or by improved efficiency in extracting stimulus, information by changing the relative weighting of the information. Is it the same as CAM stimulator? CAM is brief, it's passive, versus perceptual learning is active and prolonged. So what other things? We have video gaming. What is that? By playing action and non-action video game with better eye occluded. How does it work? It works by induced cortical plasticity and improved visual function beyond the sensitive period of the brain development. And video games induce a reduction of noise and an increased sampling efficiency, which is basically perceptual learning, as stated by Lee et al. So these are various games which have been studied. We have the Dig Dash, which is now available all over. Only thing, it often has addiction potential, especially with lockdown and children being indoors. Maybe a good idea, but it's a double-edged sword. Changing the focus from vision to binocular vision. Now talking about binocular vision. This is what we're talking about today. It's called dichoptic training. What is it? Contrast adjusted stimulus presented to each eye, brain forced to integrate into one perception. How does it work? tasks in which stimuli are presented dichoptically with the contrast of the image to the fellow eye attenuated in order to encourage binocular combination of two inputs. So basically encouraging binocularity. And dichoptic stimuli are designed so that they perceive binocularly, a patient will be able to complete a task better, like we have in video games and CureSee. We also have now transcranial magnetic stimulation. A magnetic field is generated via plastic coated coil of wire placed on the head, induces a weak electrical current that stimulates cortical areas. Again, very, very early studies have been done about it. In pharmacotherapy, there's very different rationale that dopamine has been found to reduce in the retina in deprivation of amblyopia, and increasing levels of dopamine in the retina may have a beneficial effect. So we have levodopa, citicoline, fluoxetine, which has been studied. Citicoline has been used. Effects are still a little controversial. Levodopa has been used, but Paediatric showed no benefit in children. So, and fluoxetine has been quite disappointing. But what do we have to think about in the future? Watch out for the AMPLE study, which is coming in 2021 this year. And some acknowledges to my guru, and thank you. So I hope I was able to share some latest in amblyopia, old disease, and what are different new regimens we can think of. Over to you, Team CureSee.
Thank you, sir. It was indeed a very great and insightful presentation for us all.